enjoyed being here. I think everyone had a great time last night at the Usha Utup concert. One person had such a good time, they actually left a jacket and a pair of glasses and all the excitement. So we have a volunteer down here. If you have misplaced a jacket and a pair of glasses from last night or know anyone that has, this young lady will be here for the next 15 or 20 minutes. You can claim that. Moving right along into our next session, which is the Life Sciences Plenary. At the end of the session, we're going to do another Q&A, so remember, you can submit your questions on the mobile app. I believe we have a slide up here that shows you how to do that, instructions. Just click on the Submit Questions section on the app. This session, the Life Sciences Plenary, will be moderated by Dr. Robert Robbins, the President and CEO of the Texas Medical Center. The Texas Medical Center is the largest medical center in the world with the highest density of clinical facilities for patient care, science, education, and research, and contains more than 50 medical-related institutions. Dr. Robbins, an internationally recognized cardiac surgeon, was professor and chairman of the Department of Cardiothoracic Surgery at Stanford University and the former chair of the American Heart Association of Cardiovascular Surgery. Please join me in welcoming Dr. Robert Robbins to the stage.
Good morning, everyone. Thank you for being in Houston. Sorry we didn't provide better weather. Usually it's golfing weather in December. So we have two distinguished members of our panel today. The first is Dr. Linda Chen, who's the founding chair of the Department of Genomic Medicine at MD Anderson. And prior to directing the department at MD Anderson, she was the director of the Belfer Institute for Applied Science at Dana-Farber Cancer Institute in Boston. She also serves on the executive committee of the Cancer Genome Atlas, which is a large international effort to better understand the molecular basis of cancer through genomic analysis. Dr. Chen is a world-renowned cancer biologist and genomics expert, and today she's going to be talking about really a transformation in how we care for patients through the use of technology and genomic medicine. So Dr. Chen, would you please join me on stage? And our other panelist is Dr. Spencer Berthelsen, who is the chairman and managing director of the Kelsey-Seybold Clinic here in the Houston area, a 370 physician multi-specialty group. Kelsey-Seybold recently received the nation's first NCQA accreditation at level 2 for accountable care organizations. Dr. Berthelsen is a member of the medical leadership positions both inside and outside the Kelsey-Seybold Clinic. He still practices internal medicine. He told me this morning he sees patients 2 days a week in the mornings and is frequently asked to speak about accountable care, and is really one of the nation's experts on the Affordable Care Act and how that's going to translate into the care of patients, not only in Houston, but across the nation. So, Spencer, could you join us? So what I thought we would do is to ask Dr. Chen to give you some opening remarks. He has some slides prepared, and then ask Spencer to have some opening remarks. I have an iPad that if you have questions, please go to the app and ask your questions, and I'll read your questions, and I have a few questions of my own. But I think you're going to be educated and inspired by our presentations today, and I'm going to ask Dr. Linda Chen to lead us off at this time. Linda?
Thank you. I need the clicker. There's supposed to be a clicker here. Good morning. I appreciate the opportunity to speak here. And I want to talk a little bit about some of our efforts this past year and a half in trying to rethink how we can deliver medicines in the new age of technology and how technology, which is what you all hear about, can fundamentally change the way we think about medicine. The time is now, as you have heard at this conference and in the recent years, that there's a convergence driven by advances in technology, certainly in life science and in medicine. The advance in genomic technology, health IT, and certainly the concept of convergence of disciplines is no longer strange to speak about mathematics, engineering, and life science in the same sentence, or medicines, and that's our opportunity, the opportunity to cross-fertilize. At the same time, our culture has changed. Less than a decade ago, it would be hard to imagine, but today we all want to be connected, expected to be connected, and that culture of connectivity offers an opportunity to rethink the type of collaboration and cooperation and integration across discipline that can allow us to deliver a different kind of medicines. And then big data. Big data is the most popular thing these days. We talk about it in all industries, and certainly it will impact on medicine, but how is that going to impact on medicine? I think fundamentally, it will change medicine from a practice to a science. But that's a long road, and what are some of the basics that we can begin with? So I think what all this really are telling us is an opportunity to not just fix these problems, but let's transform the way we think about the problem and the approach to it. Certainly, healthcare is a crisis, and we all recognize that. The recent IOM report, the Institute of Medicine report, actually identified cancer care as a system in crisis. So we need to rethink, and we need to think boldly when we are trying to address a problem that's in crisis. And the way I think about this is that I think we need to begin to think not just about efficiency, we need to think about effectiveness. There is a cost that's rising in our system that's unsustainable. While we think about how to reduce costs, I think we need to fundamentally think about how to increase the effectiveness of our investment in healthcare. It is not about the total cost per se, but it is the cost that we invest in it and the value we get out of it. And if we don't think effectiveness, I don't think we'll be able to give what our patients expect from us, which is outcome. So if we think about effectiveness, let's think about today's care system. The best knowledge and the best expertise resides in specialty hospitals, such as MD Anderson, expert cancer care. But as big as we are, and as big as we can grow, we can only take care of a few percentage of all cancer patients. Over 95% of cancer patients are diagnosed, treated, and managed in community setting outside the major academic cancer center, where the cutting-edge medicine is being developed and optimized. So how can we make sure that the other 95% are getting best care? Because if they don't, and they progress on their disease and end up at these major medical centers as advanced disease patients, every dollar of care we put in those advanced disease patients is going to have a less impact on outcome, ultimate cure, than if the same dollar is put into their disease at the very first point of diagnosis, at the very first point of care. So I think the important thing is, for everything we do know today, how can we make sure that best standard is being democratized and benefiting every single patient around the country and around the world, so that we elevate everyone's care and elevate the overall outcome, so that the cost that we have in the system is maximizing in terms of the return. So I think that's one place technology can do, and I'll tell you a little bit about what we're doing there. But at the same time, we're fully aware that today's best is not good enough. We absolutely need to invest in research. But we also can think about the efficacy of research and the effectiveness of that research. Many of you know that our clinical research relies on patient participation. Patients are ultimately our most important partners in this process. Patients need to contribute their information by participating in clinical trial. But we all know the statistic. About 5–10% of these patients around the world are seen in academic centers, and maybe 15–20% of them will consent to participate in clinical trial. What does that tell you? We are studying very complex problem in a very biased system, and the results are going to be not likely generalizable in every case. So how can we make sure that the investment in research that we put in have the broadest implication, have the least bias? Well, we need to accrue and engage much more heterogeneous population of patient into the research setting so that the learning is more applicable to the demographic, the true demographic of the patients. But that means we have to have a way of reach them, not just the ones who can come to us. So fundamentally, just like the first point I made, we need to change the model we think about care delivery and research. It cannot be provider-centric. It had to be patient-centric. And then finally, this is an aspect that I'm not going to talk about, but we should always keep in mind, is just because we have new knowledge doesn't mean it can really impact on patient outcomes. A new knowledge that's published at the latest journal does not benefit patient until it becomes a drug, a test, a device, a policy. Until then, it is just a discovery on a piece of paper, no matter how prominent that journal is. So we must also focus on accelerating our ability to translate knowledge into care standard, and so that that care standard can be rapidly adopted throughout the world and benefit patients. And that's how you iterate back to the first point. I'll give you a statistic. I think EGFR, which is a gene, the epidermal growth factor receptor mutation, was discovered in, I should know this, 2004, 2005, mutation of that gene in non-smoker, particular Asian descent, particular women, predict response to anti-EGFR therapy. Great, well-proven targeted therapy where the responding population is clearly defined. I think there was an ASCO survey in 2010 indicating that adoption of this particular treatment paradigm in the community setting is 12%. That's 5 years later, 12% adoption. So today, we are talking about learning and improving our understanding, our knowledge in medicine, and the way we can treat our patient on a weekly basis. How can we make sure those new knowledge and new practice care guidelines is being adopted broadly? Well, we need a system that, come back to the first point, that can allow us to democratize. So what we initiated as a pilot at MD Anderson is what I call the N of all pilot. It really tried to cover the first 2 points, which is about focusing on effectiveness of care and research. And when I say N of all, is that we want to deliver the best care eventually to every single patient, and we want to engage every single patient in our research so that we learn from every single episode of care. This is the first step we did. I think to increase our effectiveness of research, we have to fundamentally change the culture in academic medicine, change the way the research enterprise and the care enterprise in academic medicine and how they interact with each other. These two enterprises tend to function separately on different ends of the spectrum, but in order for us to do patient-oriented research and make sure that research is effective, that really focus on what the patient's needs are, we have to integrate those two. So we did a pilot in collaboration with our Department of Leukemia where we bring the research data and the prospective longitudinal care information in real time together, along with centralization and standardization of all the process leading up to the ability to do that research, such as common consent, standardized protocol of sample collection, sample transport. Not very exciting, but very important if you care about the data quality. And how that data is ultimately ingested in a standard format with QC and QA into an institution's centralized big data warehouse, which will be made available to all qualified investigator at MD Anderson, not just a leukemia doctor, not just the sequencing researcher, but everyone, because that data can be used and will benefit many others. And that is a very different culture than the way we typically operate, but we have succeeded in showing that it can be done. Here is our progress. We call them the Apollo Project, Adaptive Patient-Oriented Longitudinal Learning and Optimizations. In this 1 year, our goal was to accrue 1,000 patients. We exceeded that. We hit almost 1,300. That means since October 2012, every patient that walked into leukemia clinic went on the same consent, same process and protocol of sample collections, sample transports, sample data generations, and integration of all their care and research data. And that's different. It doesn't matter what subtype of leukemia they have, doesn't matter which attending, which faculty is actually seeing them. They all come together and agree to the common process so that we can actually monitor and map that process and make sure we have quality assurance in progress. Once we generate discovery data, such as whole exome sequencing on these patients, we link them all back into centralized big data warehouse where we begin, along with our IS divisions team, to populate that with retrospective data. In 1 year, we now have over 1 million patient demographic data, back to the very first patient MD Anderson ever seen since 1945. And their billing diagnosis, over 20 million data points on medication dispensed, and lab data, over almost 70 million data points, and all the molecular data since the day that we begin to do molecular testing in the clinic. And at the same time, we begin to bring in new analytics, such as natural language processing, to abstract data from the richest information source that we have today, our unstructured data, the history, the dictated notes, the progress notes, and we have now ingested over 480,000 documents today, focusing on, at the beginning, comorbidity and family history. And then on top of this big data, we can begin to imagine all sorts of analytics that allow us to address the challenge of improving our care pathway, understand better way to deliver medicine to these patients that on the clinical diagnosis side may be the same patient, but they respond differently. Why are they responding differently? That's where we can begin to enhance our understanding and optimize our treatment paradigm. And at the same time, it allows us to begin to think about building a clinical decision support tool. And in this case, I'm just going to talk very briefly, and we can touch on it, a question and answer. We partner with IBM Watson to leverage the cognitive computing technology to build what we call the Oncology Expert Advisor. I think of the Oncology Expert Advisor as an in silico tool that allows us to deliver expert knowledge on demand, personalized to a patient, anywhere in the world. As long as there is connectivity, internet connectivity, that allow a practicing physician in the community to have access to expertise. And the way I make this analogy is pretend a practicing physician is seeing a patient that he or she have not encountered commonly, maybe have not encountered since the training day, except she has a buddy who specializes this area. It is MD Anderson, chair of that department. She can call him up, doesn't matter what time of the day. He will answer the phone, and she will say, I have this patient in front of me. Here's everything I know about them. What would you do? And he will say, well, if I were seeing him, that's what I would do. This is what the Oncology Expert Advisor is. We want to make that buddy available to every practicing oncologist, no matter where they are, so that they can access the best evidence-based care available that day, and elevate the standard care practice that we can deliver to all the patients who cannot afford, for one reason or the other, seek expert care at a specialized cancer center. And this was just one of the results that's been reported in the Institute of Care Medicine report. Significant disparity in quality and access of specialty care in US alone, not to mention around the world. So I'll end here. And first of all, acknowledge that another thing that's really different, coming back to the first point I made, is the time is different now. We're talking about convergence of discipline. This particular project would not have been possible without bringing all these different people I listed here together in a way that we have never worked together before in this manner. And this is what today and the future of medicine will be like. Thank you.
Thank you, Dr. Chen. Now we'll hear from Dr. Berthelsen about his experience around accountable care.
I want to talk to you this morning about a transformation that is occurring in American healthcare, and it is a major transformation that we've not seen the likes of, certainly in my career and probably for several generations. And the Affordable Care Act is actually only a part of the process. It's probably the spark of it, but it's driven actually by economic forces that are relentless and are very powerful and that simply won't stop. These forces can be described by their symptoms. One is that the United States spends twice as much as the average industrialized country per capita on health care, but we don't get twice the benefit. We spend about 18% of our gross domestic product, but we are last or next to last in 10 of 12 measures of quality as measured by a recent study by the Commonwealth Fund. The reason that we scored last or next to last in so many of these measures is because of maldistribution. If you have insurance, then you get the up end of that and you get very good care. If you don't have insurance, then you don't get very good care. In fact, we have a huge problem with uninsured in the United States. It's 15% across the country. It's 25% in Texas, and it's as much as 34% here in Harris County. There's 46 million Americans that don't have access to insurance and therefore have limited access to health care. There's also a lot of our dollars that are spent, according to an opinion expressed by the Institute of Medicine, that about 30% of our American healthcare dollars spent on healthcare is spent on things that are either minimally beneficial, not beneficial, or in some cases actually harmful to patients. And another sign of need for healthcare transformation is the huge variation that we see in the practice of medicine. The Dartmouth Atlas of Healthcare has been studying this for over a decade, and what they do is they look at Medicare claims and they compare different regions and different spending levels on different conditions even within the same region. Just to give you an example of what they found is if you look at the total Medicare spending per beneficiary in Miami and you compare that to Minneapolis, that the spending in Miami is 3 times the spending on a per beneficiary basis in Minneapolis. Now certainly there are some demographic differences there, but human biology doesn't vary by as much as 3-fold on a broad basis like that. We also see that part of the problem that we have is that we have a payment system in American medicine that actually favors variation, favors overutilization, favors spending dollars on things that may actually be of minimal benefit to the patient, and it's the fee-for-service system. Almost all of our economy is based on some type of a fee-for-service or fee for a good or a price for a good. And that works in most instances where you have a knowledgeable consumer who knows generally what they want. If you own a warehouse, you know that you need 2 forklifts, not 1, not 3, and you need a forklift of a certain size. In the case of healthcare, you have a consumer typically who is not medical, who's facing a healthcare provider that has a huge knowledge advantage over the consumer. Now, the web has equalized a lot of that, but still there's a huge difference. And so that it's hard for a patient to know whether or not they need an MRI scan or if they need reassurance, but the healthcare provider does know that. So if we have a system which rewards for quantity rather than effectiveness, what we get then is more quantity. Add to that the strategy of payers over the last several decades has been to control total healthcare costs with the idea that if you discount every component of the healthcare cost strata, that what you'll get is a totally discounted cost of the total cost. The problem with that is it overlooks the effect of utilization, and utilization will trump discount every time, and so we still wind up with high cost increases from year to year. The consequences of this increasing cost of healthcare is that we have unaffordability of health insurance, and as a result, those patients come in for rescue care rather than preventative care at the very end of a very long or predictable course of disease in which they crowd into the emergency departments, which crowd out people who need those emergency departments for conditions that couldn't have been anticipated. And we have cost that continues to increase and is interfering with America's global competitiveness. We have displacement of other priorities such as education, infrastructure, defense. In fact, I heard an interview of Chuck Hagel recently on NPR in which he was describing the budget of the for the Defense Department, and about half of it is devoted to healthcare expense, either in active duty or post-active duty type expenses and related benefits. We also have it just interfering with our ordinary standard of living. We all have places to spend these dollars that could benefit us in other ways. And it's accumulating into a fiscal crisis for the government and for the country as a whole. And a lot of the budgetary concerns that you see relate to the cost of health care, Medicare predominantly and Medicaid. That is the big driver with regard to the federal budget and the looming fiscal crisis. But along comes the Affordable Care Act. It is a necessary start. Its biggest contribution to this process is that we are no longer sitting around thinking about healthcare reform. It is actually here in some form or fashion, and we have to deal with it and mold it into something that's going to be beneficial for us. It is best viewed as version 1.0, and version 1.0, you engineers know, is good, but it's not great, and it requires adjustment. And it's not until we get to version 3.0 that we're typically happy with something. Half of it is right, half of it is wrong, and you need to identify which is which. Version 2.0 will take the half that's wrong and make that half right, half wrong, and we'll iterate towards something that will actually be really quite good. The main contribution of the Affordable Care Act was insurance reform, and part of the Affordable Care Act could only be done by government, and that is take out the pre-existing condition exclusions. That couldn't be done by industry because of competitive forces. But now that that's removed, we focus on making all of our citizens well. The cost reform ultimately is the big part of and the heavy lift for healthcare reform. And that can really only be done by the private sector because it requires a high level of innovation that simply can't come from government alone. So this innovation is actually well underway, and it's the accountable care movement. Accountable care is actually a newly coined term, but it's actually not a new concept. It's been in our medical community for quite some time in the form of medical group practice. Mayo Clinic is probably the oldest and best recognized example of this, but there are others that are developing. It is the American innovation that is going to be what rescues us and keeps us from the default conclusion, which is that the healthcare economy needs to be centralized, as what has often happened with other industrialized countries that have dealt with their cost problem. What accountable care actually does is that it dedicates itself to raising the value of care, which is a ratio of quality over cost, raising quality whenever possible and taking out unnecessary costs, this 30% that the Institute of Medicine believes is there. It involves coalescing together a group of healthcare providers for the full spectrum of healthcare that dedicates itself to the prospect of taking out cost and raising the value. It involves information technology investments in management systems for medical management, and investment in changing the payment system, so payment reform, where healthcare providers are paid based on achieving desirable outcomes for a population over a period of time. So payment, desirable outcomes for a population over time is where we should be heading. It is a proven model. There are multiple examples across the country. Mayo Clinic, Geisinger Clinic, Intermountain Healthcare, Kaiser in California, Scott and White in Central Texas, and Kelsey-Seybold in Houston are examples. In the case of Kelsey-Seybold, which I'm the chairman of, we've been able to demonstrate consistently a 15 to 30% savings, lower cost of total care when patients come to us through an accountable care type model. The future actually is bright. There's no reason to be despairing of what will happen. The Affordable Care Act is not the final state. It does require more work. It will require the Congress to become less polarized and start working on modifying the ACA to get it to something better. That will take some time, but it will happen. but there is change that's already occurring within the medical community with this accountable care movement. So there's reason for optimism. There is enough money in the system, twice as much as the average industrialized country. There is enough time, but not enough time to waste. It is a successful, proven model, and change is going to be for the better, ultimately. What I would say to the audience is that it does require the participation of the community as well, including the employer community. It requires that all employers and all purchasers of healthcare, either on an individual or on an employer basis, be selective. No longer can you assume safely, that all medical care is the same no matter where you buy it, but actually it will start to segment out into these higher performing styles of care and those that stay with the current model. So I would say it's important to be selective. It's important to hold the healthcare delivery system that you engage to accountability for both quality and cost, and that you demand the best value and understand that value is not universal, but actually will start to become a competitive difference from one to another. So with that, I'll conclude my remarks, and Bobby, we can proceed.
Great. Well, thank both of you for your excellent opening remarks. We have about 20 minutes for questions, and I'll get to your questions. Thank you for sending them to me through the app you have there. I think the first thing that I would like to ask is, it's about, and some of the questions get to this, so I'll kind of paraphrase with some of the thoughts I had, was if you see one of your patients in your clinic who has a melanoma, and you want to refer the patient to Linda at MD Anderson, you pointed out that there's 30% waste in the system. What do each of you think about the future of not only a health exchange in terms of electronic medical record, but when will I be able to have all of my medical record on my device so that I can move it or on a card or on a chip or on a USB stick that I can give to the doctor? Because MD Anderson may not be able to interpret, download, use your CT scan data for a patient, or they may not think that it's the higher quality for them to be able to use it practically. So I guess the question would be for each of you, first of all, medical record exchange, which is one thing. I don't know what system you use, whether you use Cerner and you use Epic or they're different. But there's an issue, even if you both use Epic, of transferring data electronically. And the second is, when is the patient going to be empowered to have their data to walk around and use it? So maybe, Spencer, you could start.
So that's another sign of reason to be optimistic, is that there are great strides being made in bringing medicine into the digital age. Kelsey-Seybold has the Epic system, which is the dominant system in the country, particularly for large healthcare organizations. It's about a $34 million investment for us and ongoing investment to keep it refreshed. It is comprehensive so that all the data occurs in that electronic medical record. So not just that doctor that you're seeing, but all the specialty, all the radiology, all the laboratory, all the pharmacy, and it has built-in decision support and medical intelligence that prompts the doctor to fill in the gaps of care that otherwise, because medicine is so complex, that the doctor may not always remember. With regard to interconnectivity, there's also progress being made there. There's an organization that we belong to that is making progress called the Greater Houston Health Exchange, Houston Health Connect, which will connect up the institutions in Houston with a ability to share all the basic part of the medical record from one to the other. So that I think that we are now emerging into an era where we will no longer have duplication or question marks about what a patient has had, what the results are, but that's developing very rapidly. With regard to patients having their own medical record, that's happening as well. In EPIC, there is a portion of it that is devoted towards giving the patient access to their results and to their important parts of their communications with their doctor. So today, at Kelsey-Seybold, patients receive their results online. It stays there for them. It has commentary from the doctor about what those results indicate. If they have questions, they can message the doctor back and no longer have to call in and either wait for a call back or wait for the doctor to come to the line. So I think progress is being made, and we look forward to the day where this connection is fully established with all medical institutions, but it's getting there, and I'll pass the microphone to Linda.
I agree with, I think that's where the health IT technology revolution really will change the way we communicate among providers and with patients. And I think those things are happening in parallel, but the one additional track that I want to add to, which I think is very much under the Affordable Care Act mandate, is the way I imagine the new technologies, and it doesn't have to be the oncology expert advisor, but some form of clinical decision support to that link to the latest and current up-to-date evidence-based treatment, is the ability for that clinical decision support to be available to the physician at Kelsey-Seybold with that melanoma patient, so that the same expertise, medicine is so complex, none of us can know everything. Nobody can keep up with the literature. So the relevant literature, the expertise personalized to that patient is available through that system, to that physician, for that physician to decide, number one, can I manage this patient here? With the same level of evidence, the same kind of recommendation that he or she would have gotten had I sent them to MD Anderson. And at which point do I need to really refer this patient to a specialty hospital? And I think that's really important, because what we don't want is for physician to feel like, because every time I send a patient to a specialist, it costs more. I should try to manage as much as possible, which is right. But we also don't want them to mismanage the 10% that absolutely needed more specialty care. But how do they know which is the 10%, which is the 90%? And that's a level of enablement on the technology side, not just to make sure the information is there. There's a whole level we call knowledge, art of medicine, that unfortunately cannot easily be translated into a flow chart. How can we make sure that knowledge is being used at the very first points and second point, earlier points of care, so that the decision is optimized? It will never be 100% accurate and correct, but at least optimized to the best we can based on the knowledge of today, so that we can make sure the patient who need the more expensive specialty care will get it. The patient that don't need it will still get the best care available of that day.
How far away are we from, if I'm a woman in India and I have breast cancer and there's a genotype of my tumor, and I want to get into a clinical trial at MD Anderson, but maybe MD Anderson doesn't have any availability. Will there ever be a time in your mind when the genotype of your tumor will be predictive of which medications you would respond best to and which clinical trials are available around the world?
Yes. So before I answer that question, I actually think India is a great case to make that, because I recently came across this referral where in India, breast cancer treatment is very good on the surgical side, but a lot less experience in using chemotherapy and targeted therapy and hormonal therapy in managing these patients. So when the patients refer, they have all the relevant tests, that prognosticate and determine that they really would benefit from chemo and hormonal therapy following surgery. The physician in India were uncomfortable doing that and want to know, well, can MD Anderson physician tell me what to do by email? Well, as much as one would like to help, these things don't happen, happen in a much faster time frame than by email. Without a full medical records transfer of knowing what's happening to the patient, you really can't manage the patient by email. So that's a case where what you really want to have is the physician in India having access to that knowledge and experience to be able to manage that patient post-surgery on hormonal therapy rather than just post-surgery and be done with it, because then the outcome of that woman will be less optimal compared to what they would have been had they gotten the full therapy. Now, in terms of clinical trial, I talk about the N of all. I think exactly to that point, we need to expand the way we think about clinical trial. We need to be able to accrue patients in community setting, globally and nationally, into clinical trial. So that is another layer of infrastructure that needs to be built. It's not just being able to say the oncology expert advisor today will automatically, even if there's standard therapy that the patient is appropriate for, it will automatically match them up to open available clinical trial at MD Anderson. Because it is a conversation that should be had between the physician and the patient, whether that standard care therapy is good enough for that patient and whether there's another option. But what we need to now build is, in that community setting, the appropriate infrastructure so that that physician can run the clinical trial. Because the idea that everything had to be done away from home for the patient in a specialty cancer hospital is unscalable. Not to mention, it's not optimal for patient outcome. We all know patients recover better in their home environment with the right support. So how can we ensure that continuity of care and continuity of research even when the patients are at home? It all comes back to rethinking what our healthcare system is. It should not be provider-centric. It has to be patient-centric. And we have the technology to do it today.
So Spencer, I think India, at least in my field, is a great place for us to learn about the three parameters that I think that we're going to be moving to with the Affordable Care Act, and you mentioned them in your opening remarks, which is the highest quality outcomes at the lowest cost with the highest customer satisfaction. For instance, in the United States, the cost, and it's hard to get real cost, but roughly the cost of doing coronary artery bypass surgery on a relatively healthy patient with a 4 or 5 day hospital stay is around $25,000 to $30,000. Whereas in India, that same operation with the same outcomes, quality outcomes, can be achieved for probably a third of that. Now, there are all kind of issues around cost of labor and disposables and things like that. But there's certainly process, and it's not only for cardiac surgery, but for cataract surgery and things like that. So it's the so-called lean technology that came out of Toyota, or Six Sigma to decrease variation that GE has popularized. What do you see? You obviously are able at the Kelsey-Seybold Clinic to reduce costs. Where are the areas that others could learn from you and our friends in India around how you actually reduce cost?
So cost is reduced by a number of means, and I think that the underpinning requirement is to have a culture of cost reduction. And today in American medicine, the culture is not headed towards cost reduction yet. But when you have a group that is assembled together into one of these accountable care organizations, they can focus on such things as organizing it such that if a patient doesn't need to be hospitalized for a transfusion, that they can receive that as an outpatient, and moving more things that would occur in the hospital to an outpatient setting by making the outpatient capabilities stronger. But it also involves putting together programs that will assist patients through a course of illness that otherwise would be more uncoordinated and therefore more subject to complication and hospitalization. A good example is that we now have medicine that can treat a common condition called deep venous thrombosis as an outpatient. Normally that treatment would have been using intravenous heparin as an inpatient, and at least a 6-day course starting the heparin after the diagnosis is made and then converting to an oral anticoagulant. Well, today heparin can be given as a subcutaneous injection as low molecular weight heparin and avoid the hospitalization altogether. And it's been proven to be as safe as the hospitalized approach. But that requires a number of things to be put in place to allow that coordination, because you have to put more effort into getting the medicine to the patient, getting the patient trained or home health care so that they can have the subcutaneous injection and the amount of monitoring that's necessary. So it's that multiplied by, I don't know, 200, 500, or 1,000 that are the opportunities to save these large amounts of resources. The other big example is case selection for technology. In the past, we had always assumed that if our patient had a chance of benefiting from the technology, we would apply it. But in the case that we have today, where we understand we have limited resources and to spend this technology resource here means that we won't have it for someplace else, we have to ask ourselves instead a worth it, not worth it type question, both from the perspective of the patient, their own risk of morbidity and mortality, their own ability to go through the technology and the nuisance associated with that, but also the fact that it's drawing from resources that otherwise we will not have in other more productive areas. So we're now having those discussions in American medicine, and those will lead towards a more rational application of the technology that continues to emerge and continues to outstrip our ability to pay.
So this is a great question from the audience. What are your thoughts on the FDA ban on marketing 23andMe kits? I'm sure, Spencer, you get patients who come in and want to know whether they should go to 23andMe, and they're going to bring back the results and then ask you, what do I need to do, doctor? So either of you have thoughts about the FDA banning 23andMe kits? Linda?
First of all, I preface by saying I have not followed every piece of development in this event, so I might be missing some nuance on this. I think, to me, there is a level that I don't want to necessarily use 23andMe as a specific example. I think in the area of genetic and genomic in medicine, there is a blurring of the line between science and medicine, discovery science and practicing medicine. I happen to believe those two are very different. Given the speed and of the tremendous revolution that genomics came on the scene and the potential of it, I think is moving into clinical practice very rapidly. But we know that today, much of what we can detect in the genome, whether it's germline or somatic genome, we actually don't fully understand what the meaning of it is. In other words, the subset of information that we can say they're truly actionable from a medicine practice point of view is very small. So the question really that I think the bigger question that the 23andMe is putting on the table is, what do we do with information that really has not been, the full implication that we don't truly understand? When we say someone has a mutation in a gene that we think in a discovery setting has been shown to be important in cancer, but we don't know how that's going to change the way we manage the patient, whether we have a new test to do, or whether we have a new medicine, or whether we change the way we treat the patient. If we don't know any of that, have no clue, is it worthwhile? And is it going to do harm or do no harm? Is it going to benefit the patient for the physician to know about it? For the patient to say, now I know I have mutation in gene X, what are you going to do about it? Well, there may be nothing, and in 99% of cases, nothing we know what to do about. So why do we want that information? We absolutely need on the discovery side, research side, because that's what the focus of integrating research with care is. But we should make a distinction. In my view, I've been in private practice before and now in academic medicine, I truly believe discovery science is fundamentally different from medicine. And the distinction, I think, to me, is key to this whole 23andMe question. So I don't know what the right answer is, but I think we do have to think about the objective of discovery and the objective of medicine are two different things. They're interdependent, and the more we align them, the better we do in terms of advancing care, but let's not think them as the same.
So we're running out of time. First of all, I'd like to thank all of you for being here, but more importantly, for overwhelming with a number of questions, very good questions. So we're trying to get to them. There's a pattern here, and this morning when we met before we started the panel, we were discussing some current things in the news, and there was something in the news about if you're in California and you got on the website to sign up for the exchanges, even if you were just browsing it, you got an email, even if you didn't sign in, from a third-party vendor saying, giving you encouragement to sign up. So there are all kind of security issues that come about around that. There are many security questions here in the questions I've received. So maybe as sort of the final thing, since we're running short on time, maybe talk about security and HIPAA. The P in HIPAA is for portability, but I think that people are very concerned about the privacy of their data. So maybe we could end with talking about some of the security issues around electronic data.
So this audience will fully understand security issues with regard to information technology. And the Affordable Care Act was put together 3 years ago, and you'd think they would have enough time to get the website together such that it would have these security issues corralled and addressed, because the technology is there to put in fairly deep levels of security protection. My understanding is that even the federally facilitated exchanges have a lot of security holes that normally shouldn't exist with a commercial website. But having said that, we do have the technology that's going to close these holes, and eventually it will become more secure. It's disappointing that it's not as secure as it could be today. But I would also ask for everybody's patience, because one of the bright, shiny objects in the Affordable Care Act actually is the exchanges, now called the marketplaces, because it's a democratization of access to health care, where number one, it's going to be affordable for people who couldn't afford it before. It'll cost more for people that could afford it before. That'll go up. So there's issues with regard to winners and losers. But as far as the marketplace goes, it is a good place for an individual to go and to shop on an apples-to-apples comparison basis your options for healthcare insurance. And that is only going to be for the better for the individual, for competition, and ultimately through competition, lowering the cost of healthcare insurance and healthcare. So I see these security issues as birthing issues that ultimately will be corrected. It's too bad that they're there and that they put this off on a bad start, but it's a temporary problem as I see it.
I think I agree with that point. I think there's no question that technology today, and you all know better than I, can create an infrastructure that's fully secure for this information to be exchanged. And maybe it takes time, but it's doable. It would never be 100% resistant to hacking, but certainly it can be as good as, if the CIA can have it or the banking industry have it. I don't see any reason why healthcare cannot use this IT infrastructure to share information. That said, I think there's also a culture shift that needs to happen, or that should happen, I should say, which the government can help significantly. And you spoke to that, the fact that only the government can mandate that you cannot use a pre-existing, I forgot the exact term, I don't want to say the wrong word, that the pre-existing health condition to prevent someone from accessing a certain insurance. I mean, that kind of policy level is a beginning to allow us to think about patient privacy with respect to information. On the social network, people share a whole lot of personal information out there. They are not inhibited on that by most of them probably should be a little bit inhibited by that, but they are not. Why is that versus their personal information in health? What's the difference? It comes down to what the information can be potentially used against them. And I think culturally that is going to change, I think, as time goes on. The millennium, one day, the generation that's going to grow up now will have a different viewpoint on that. I think government policy, such as this one case, but there are many other, may help us change the society pressure on what piece of information can and cannot be shared. So I think those two things need to happen. But I don't see any reason, and I don't see medicine being able to advance without us being able to share this information digitally.
So the last question I think, Spencer, I'll give to you, and it's a simple question, but I think it's important as all of us, read and hear more about. Could you just give us sort of a simple difference between accountable care and affordable care? When you hear those terms used, because often the ACA people have confuse the Affordable Care Act for the Accountable Care Act. So maybe just a brief difference between the two.
So the full name of the healthcare reform legislation is the Patient Protection and Affordable Care Act. And part of that legislation is that they created for Medicare beneficiaries an entity called an ACO, and that's the Accountable Care Organization. That's the first time that it appears that I know of in law. But the concept of accountable care organizations is much broader than the Affordable Care Act describes. It's part of what's happening in Medicare, which I think is a very limited application of the accountable care concept. But what's happening across the country is accountable care organizations are forming. The well-established ones that I described, that I listed, but also ones that had not formed together into accountable care organizations. In Houston, we have Memorial Hermann is probably the most advanced with regard to a hospital-based accountable care formation. But other hospital systems around the faculty practices and other independent practice associations are coming together to form what could be referred to as accountable care organizations. So it's a concept that is much broader than is related to this federal law, but it was accelerated and stimulated by the passage of the federal law and focusing the country on raising the value of healthcare that we spend our dollars on. And I think for the most part it's for the good, and we are going to see and do see today tangible results in terms of reduced cost and increased quality.
Okay, so Dr. Chen, Dr. Berthelsen, thank you very much for your time, your expertise, and the wisdom you've imparted. Thank you all for being here and for your excellent questions.
Thank you.
Thank you all again. We wanted to just take a quick moment for a recognition for Robert, Spencer, and Linda, and thank them again. Why don't we give them another round of applause? We have Whitty Bender, our conference chair, here to present the awards. And we'll do another quick photo op. Great. Thank you all again for that wonderful presentation. Moving right along, our next session, as scheduled, will start at 10:30 in the breakout rooms A, B, and C, located to your left. We have a breakout on India, Innovation, and Life Sciences. The break rooms, again, to your left here, same as they've been the last 2 days. We'll do a short break before the sessions. We did want to make a little programming note to check your mobile app. We'll have an update on a possible interview with Miss America, a phone interview. So check your mobile app on the status of that. We look forward to seeing you back here for lunch. Thank you.